Okay, so the recommendations that I wanted to talk about, these ones come from the CDC um, when it's related to non-cancer pain or when you're trying to treat non-cancer pain. So obviously, people are, end-stage cancer or terminal cancer pain. Um, those recommendations are definitely different, and that's, when people are in pain, they definitely, we want to get the pain treated. And I don't think any practitioner would ever want to see a patient suffer unnecessarily, um, or withhold medication that would make their um, time more comfortable. But in non-cancer pain treatment, there's a term that we use. It's called a morphine milligram equivalent. So non-cancer pain, the CDC recommends that you don't prescribe over a 50 MME or morphine milligram equivalent. What 15 or 50 milligram MME is about, it would be equivalent per day. 50 MME per day would be equivalent to 10 5 milligram hydrocodone tablets. So most of the time, say you go to the ER, bad sprain, or you go, you get a broken finger, or you get some dental work done. A lot of times, the doctors could prescribe hydrocodone 5325. So that would be that kind of the standard pain treatment. So you'd be using up to 10 of those a day, which is actually quite a bit. If you're opioid naive, that would probably cover most of us. Um, so if you are a naive patient, if a patient presents with a prescription for, 240 hydrocodone 5325 to my pharmacy, I have no history of them. I go into the Arizona database. There's no history of them there. A red flag should go off. I should be wondering, this seems like quite a big dose. You're getting 240 in a month. You're over this 50 MME equivalent per day. It's quite a bit for somebody just to start out on what's going on. Why is somebody kind of prescribing this? So it's a phone call to the doctor's office. I want to know, what kind of pain they're treating. What's the underlying disease state? Maybe do a little rundown of what they've tried, why they've gone to this. Have they tried some other non-opioid treatments? And then at most, if they are in at most, the CDC really doesn't want to see doses above 90 MME a day. So if you kind of figure, that'd be quite a bit of hydrocodone, quite a bit of oxycodone. That'd be about 9 tablets of a 10-325, which would be of hydrocodone, which would be quite a big dose for somebody to take, or 60 milligrams of oxycodone to take per day. So what are some of the other therapies that they could be put on to, to treat their pain? Real quick, they should have tried acetaminophen, an NSAID, topical pain relievers, physical therapy, exercise, cognitive behavioral therapy. There's certain antidepressants that can treat certain types of pain syndromes, anticonvulsants, such as like gabapentin would be one of them. And then it's even recommended that even medical marijuana would be a safer alternative than getting somebody started on an opioid. Are some things that probably, in non-cancer pain, that somebody should try. Now, if it's an acute, post-surgery, they're going to go to an opioid pain reliever. It's just going to be for 5 to 7 days, quick therapy, they're off. There's not going to be really hard, any issues with that. So, some of the things that we, if the therapy is for non-cancer pain and the recommendations really, the longest duration they say is as 90 days. So if it's going to be using it past 90 days, they need to go back to the start. Why? What else can we do to treat this patient? What's the underlying syndrome? Is there surgery? Is there some more therapy, physical therapy? Is it a certain joint that needs to be worked on? What else can we do to keep this patient off this opioid for more than 90 days, just so it doesn't become a habitual thing with them. Some of the risks, I just wanted to go over real quick, associated with long-term opioid abuse. First off is abuse and misuse. So the longer a patient is on opioids, their chances of abusing them or misusing them go up. Arrhythmias, diversion, which is putting it in, selling it or diverting it out of the, from your prescription to somebody else, or giving it to people that's not prescribed for. Drowsiness, drug interactions. I was just talking with another pharmacist that's on our local area. They call it the MAT Force, and they're kind of over the county as far as like the opioid epidemic for the county and illegal drug use for the county, and they're seeing certain combinations kind of come up in all of these overdoses, and it was benzodiazepine, which is like a diazepam or lorazepam, alprazolam, I don't know if you guys have heard that, an opioid, either hydrocodone, oxycodone, gabapentin was also mixed in there with methamphetamine. So it's kind of this lethal cocktail that kind of people have been taking, that this interaction that's kind of triggering these overdoses. Some of the other risks associated with long-term use, dry mouth, tooth decay, GI problems, constipation is kind of one of the main side effects with opioid use, nausea, vomiting, hyperalgesia. So say you get put on an opioid for a long time, you're on it for 5 years, all of a sudden your pain sensitivity actually goes up. So little pains that you would have experienced before that you would have just not really paid attention to, now any little pain is a big pain. So that's kind of the problem with using opioids for too long, is that they stop working first off, and then they make your pain sensitivity go way up. So you have to have more pain medication to be able to cover your pain. Or an inadvertent household member exposure, increased fracture risk, overdose of death, physical dependence, intolerance, and slow or shallow breathing. So what are some things that people can do to help kind of curb? In our state, and I think most states now do, where you can pick up, just go up to a pharmacy, you can get a naloxone prescription, and that would be like a rescue medication. So there's nasal spray, there's an injection. If there's somebody that's illegally using opioids and family members know it, they still want to be there for them. They don't, they can go get a naloxone injection or a nasal spray. So if there is ever a risk of an overdose, they can have that around or have that on board and help with any overdose. Some other things would be proper disposal of opioids or medication. If there's bottles of hydrocodone sitting in your cupboard or sitting in your parents' cupboard or your grandparents' cupboard, and they're not using it, it's probably a good idea to get rid of those. Here, the recommendation that I usually give people, if they don't want to take, there's disposal sites at police stations. I don't, some people are comfortable doing that. Some people just, don't want to mess with that. I recommend mixing it up in some wet garbage or just some nasty kind of garbage and throwing it out. If that's not a possibility to you, the FDA says you can actually flush those down the drain or flush those down the toilet, where usually most medications you don't want to do that, but with opioids, because of their